I have two bills here before you tonight dealing with the exact same subject, which is the certificate of needs. In the past, I've given a more drawn-out history of certificate needs and things like that. I do have three experts, two from different think tank organizations and one from our own Providence College. I'll allow them to provide their own introductions as we get into this. Certificates of need were originally conceived by the federal government back in the early 1970s as a way to restrict access to health care. That's why they came up with them, to restrict the access under the idea that if you restrict the access, then the costs would come down. And unfortunately, with the disconnect between with our third-party payer systems and the individual not having to make specific cost decisions, that calculation failed. So I want to say mid-'80s, maybe. I think mid-'80s, the federal government realized how badly they messed up, and they removed the general requirements for certificate of needs across the country. Again, I'll let the only points I want to make is I have no doubt. Everybody knows recently that our largest hospital system acquired 2 hospitals in Massachusetts. And in my mind, there's 2 reasons for that. One, obviously the reimbursement rates are higher, and 2, their certificate of need process is a little bit less burdensome. And with that goes their investments. If the certificate of need process is less burdensome, where are they going to invest their money? For example, and I'm going to roll right into my second bill. The first bill removes all certificate of need processes together. My second bill addresses the fees. In order to just to apply to have the certificate of need request implemented, you have a minimum fee plus 0.025% of the capital cost outlays. To give you an example, if you read the Providence Journal today, you found out that the hospital up at Zambrano is expected to cost around $197 million. That's a roughly $500,000 fee for a facility of that value on a capital cost estimate to even request moving forward with it, not knowing whether or not it would actually be accepted. So you can see that's a barrier to having a hospital system come in here and spend large money to improve our local healthcare systems. So again, the first bill, quite frankly, eliminates all certificate of needs in the state of Rhode Island, and the second bill takes a more laid-back approach and limits the fees to a maximum of $25,000, so that, again, even the state, by the way, is responsible for applying for the certificate of need. So Zambrano Hospital is going to have to pay that $500,000 in order to even apply to move forward with that project. So again, I will leave it up to the experts. They have studied this from an academic perspective. And again, I think you guys have sat down and had a conversation in terms of how you guys will go, and I'll leave it to you to conduct the introductions and provide some information to my colleagues. Thank you.
My name is Jamie Kavanaugh. I'm an attorney at the Pacific Legal Foundation. Even though we have Pacific in our name, we're a national public interest nonprofit. In fact, we're representing new clients in a case in Rhode Island right now, an eminent domain matter over in Johnston, and have represented other clients in Rhode Island in the past. So a lot of our work focuses on protecting private property rights, but we also work to protect the right to earn a living. Healthcare is something that's really important for everyone, but it's also the way a lot of people earn their living. And so we work to make sure that these people are free from unreasonable government restrictions and can provide the needed care in their communities. So certificate of need laws are one of these restrictions that really disadvantage small, niche, innovative providers, new providers. I was actually just testifying at a hearing on certificate of need reform in Connecticut earlier this week, and the chair of that health committee, who is also a physician, was talking about this point on his own, bringing up the fact that the current laws advantage the existing healthcare systems, and one of those reasons is because it's so expensive and time-consuming to apply for a certificate of need. Small providers who may see a niche market for their service don't have the capital and don't want to go through the risk to apply. And we know this at PLF because we're representing providers like midwifery groups that want to open the first birth center in Iowa, and they can't do it because of certificate of need laws. I have represented Nepali immigrants in the past who wanted to open a home health agency that offered culturally and language appropriate care, and they weren't able to in the Louisville area because of certificate of need laws. And so these are the types of people that would be filling in these gaps in community coverage and aren't able to do so. So I direct you to the written testimony that I submitted. It's quite lengthy. It's filled with lots of citations, and I hope you have a chance to review that. But with my time here, I'd actually like to talk about how this bill can improve healthcare affordability in Rhode Island. Healthcare costs, as we all know, are a problem for all types of payers, whether it's government who's paying, whether it's individuals with private insurance. And when we have this conversation in here about healthcare, we're often talking about the need to decrease government spending in healthcare. But we want to, or at least improve its efficiency. But we don't want to forget that many people that have private insurance still can't afford healthcare or still can't access it, can't find it. But many people with commercial insurance can't afford their copays and coinsurance and deductibles and out-of-pocket maximums, everything that you'd have to do to really get the full coverage. So an estimated 5.2% of adults in Rhode Island have some form of medical debt. And in fact, the high amounts of medical debt led the Office of the General Treasurer to create a medical debt relief program in 2024. So while forgiving medical debt is an important goal and life-changing, I'm sure, for many people, if you have that piece here in Rhode Island, but you don't do anything to address healthcare costs, then these same people may end up in medical debt again, and it's going to be a revolving program that never ends. So I see that as the first step in, recognizing that we need to control healthcare costs. And the evidence is clear that certificate of need laws result in higher healthcare spending. Healthcare spending in states with certificate of need laws is higher whether you look at it per service, per patient, or at overall government expenditures. So just a few of the studies, here are the findings from just a couple of the hundreds of studies that have looked at certificate of need. Hospital charges in states without certificate of need are 5.5% lower 5 years after repeal. Certificate of need laws are associated with 10% higher variable costs in general acute hospitals. Certificate of need laws are associated with higher Medicaid costs for home health services. Medicaid reimbursements for total knee arthroplasty are 5 to 10% lower in states without certificate of need laws. And I should have mentioned that 40% of the country live in a state with zero or very limited certificate of need laws. So it's easy, you'll hear more from Dr. Bailey who studies this, but it creates a good contrast and allows economists to study this issue very clearly and see what the outcomes are in states that have already repealed their certificate of need laws. Because at one point, every state has had a healthcare certificate of need law. But now many states have freed their residents from these restrictions. So allowing more providers is a proven way to decrease healthcare spending because having more providers also prevents monopoly pricing. A Yale economist, Zach Cooper, who's been studying healthcare costs and pricing for several years, finds that prices at monopoly hospitals are 12% higher than those in markets with 4 or more rivals. So it's very important to allow new healthcare providers to come in.
Good evening. Thank you for the opportunity to testify today. My name is Alistair Whitney, and I am Legislative Counsel at the Institute for Justice. IJ is a nonprofit public interest law firm that works around the country to protect folks' economic liberty. And as part of this work, we have worked in both state houses and courthouses to advocate for the repeal against certificate of need laws. And just for the record, I'll be referring to determination of need, certificate of need interchangeably in my brief presentation today. I want to echo everything that my colleague, Ms. Kavanaugh, said, so I'll lead with that and also point you to my more fulsome remarks in my written testimony that I provided to the committee. But in sum, certificate of need, has harmed patients, hospitals, communities, and payers in this state. And these laws are barriers to entry that more often than not protect market incumbents at the expense of new market entrants and patients. The predictable effect of artificially choking the supply of services in a market where demand steadily increases is higher prices, reduced availability, and in some cases, reduced quality of care. As we all witnessed during the pandemic, these harmful effects are most acutely felt by low-income individuals and members of marginalized communities. And this is not just my organization's opinion, the research backs it up. Another major problem Don represents in this state, and this is something that both my colleague Ms. Kavanaugh and Representative Place mentioned earlier, is that Don has a chilling effect in discouraging healthcare investment and the attraction of medical talent to this state. If you're a business owner and you want to open up a hospital or an inpatient rehabilitation facility in a rural part of the state or in an underserved part of the state, the first thing you have to do is wait. The Department of Health only accepts applications for determination of need twice a year. After that, you're looking at spending tens of thousands, potentially even hundreds of thousands of dollars just to file that application. And then after that, it can take months before you even get a determination. Meanwhile, competitors can intervene. You have market monopolies, entrenched healthcare providers, incumbents can come in and lobby the Department of Health to deny the application for a determination of need. This can be illustrated actually, and by the way, I will say that that just adds hundreds of thousands of dollars, typically more, when you have to get lawyers involved, and it can take years and years of litigation. We've seen this most recently, actually. There was a case quite recently with a business that wanted to open a rehabilitation facility in a small town outside of Providence. After years of litigation, hundreds of thousands of dollars spent on attorney fees, they were finally able to do it. But imagine if you're somebody wanting to open up a business and provide services to your community, and you see that's what happens. That's the cost of even trying to do that. It's a chilling effect. One final thing I will note is, like my colleague Ms. Kavanaugh said, the issue of certificate need reform is really bipartisan, and it's really, it's across the country. Texas, California, Pennsylvania, three states that perhaps couldn't be any more different politically, culturally, geographically, all have eliminated their certificate of need laws completely. There are several other states that have completely eliminated it, and Florida and South Carolina are two states that have, and New Hampshire recently significantly reformed their laws. This shows that it is a bipartisan issue, that people across the country are seeing that these outdated laws are incredibly harmful, and it's time for them to go. One actually final note is that on the bipartisan nature of this reform is that every single presidential administration since the 1980s, every single one, has criticized certificate of need as a barrier to accessible healthcare accessibility, quality of care, and healthcare cost. I urge the community to support these bills. They're great bills that will go a long way, especially the repeal legislation. 5355 will go a long way to improving those things in this state.
My name is James Bailey. I'm an associate professor of economics at Providence College, although I should note that I'm here to speak only on my own behalf, not on the college's behalf. I suppose I'm here to speak as a resident of Cranston in Representative Handy's district. But I have been studying certificate of need laws for about the past 10 years and have published 8 peer-reviewed academic articles on them now. When I first heard about these, probably about 15 years ago, I was just surprised to hear that this was a thing in the United States. Just in most industries, if you want to open a business, you might have to get a license to prove that you're sort of qualified and certify your high quality. But generally, you don't have to prove to the satisfaction of a state board that there's an economic need for the business you want to start. That's sort of up to you and the potential consumers, right? And then because if you're the one that opens a business and it turns out there's no need for it, you, the entrepreneur or the provider, are the one who's going to lose out, right? So to try to quickly sum up some of the research here. So when I first started on this, it was because Chris Conover and professor at Duke University, he had been working on this earlier meta-analysis of systematic review, trying to sum up all the academic literature on the subject, and he was trying to retire, and so he asked me, hey, could you help me with this and finish this? And at the time, there were about 90 articles that had looked across states to try to evaluate what happens to all sorts of outcomes in the states that have certificate of need programs compared to the ones that don't. And looking at those 90 articles, we tended to find that certificate of need programs led to higher spending and less access to care. Since then, I've written a lot of my own articles to contribute to the literature, and they tend to find similar things. For instance, that in the Con repealing states, when you do repeal Con, you tend to see something like a 5% drop in healthcare spending, which I think is driven by, you get these new entrants, and that competition can lead to lower prices. Because you have more providers around, there's more access to care, people do use more care, right? And so you would wonder, okay, if we have more providers, right, is that going to make spending go up or down? Because in general, it could go either way, right? Either there's more providers so people can consume more services, higher quantity of care, spending goes up, or you have more providers, which could drive down the prices, right? In this case, the price effect really seems to dominate, right? And so when states repeal Con, you get the additional competition, and so the lower healthcare spending, as well as, of course, the improved access to care because you have more competitors around. So just revisiting, to fill out a little bit more about the history of Con here. So a few states started passing these laws on their own, starting in New York in 1964 with the idea that this could reduce spending. The federal government in a 1974 law pushed every state to adopt Con because they thought it would reduce spending. Within about 10 years, they changed their mind, I think partly as a result of the evidence of seeing how it worked out, and partly as a result of changes to the Medicare program, moving from a cost-plus reimbursement system to more of a fixed-fee reimbursement system, which removed this incentive to overbuild that Con was passed in the first place for, right? And so ever since the early to mid-1980s, like the other witnesses said, every presidential administration, especially the competition agencies, like the Federal Trade Commission and the Department of Justice, have been suggesting, like, hey, yeah, if states should probably repeal these in order to allow for more competition that could promote access to care and reduce prices. You saw a lot of states repeal right away in the mid to late 1980s, as soon as they were legally allowed to. Since then, Pennsylvania repealed in '96. New Hampshire was the most recent full repeal in 2016. But since then, like Representative Stewart alluded to, we've seen several partial repeals or like almost complete repeals, like in South Carolina, Florida, and Montana, where, as I think Representative Boylan mentioned, like, what is this covering, right? There's just a ton of variation from state to state in which types of facilities or equipment are required to apply for a certificate of need, receive a certificate of need before they're allowed to open or expand. And in some states, it's just one or two things, like, say, just nursing homes or just ambulances, whereas some other states, like Rhode Island, have these very comprehensive programs where, it covers almost everything. If you want to open a hospital, nursing home, substance use treatment facility, do home health care, buy major equipment like an MRI, right? It covers almost everything in Rhode Island right now. So I would say we're more on that relatively high end. But just looking across all these states, both comparing the states with no-con programs at all, like New Hampshire, California, Pennsylvania, as well as some of the programs, states that might have con, but it covers relatively few things. What we do tend to see over and over is lower spending and improved access to care in the repealing states. There are, of course, a lot of ways you could go about this. And I think Senate Finance will be also considering today, part of the governor's budget that would make a different con reform. But I would say this is a relatively well-researched topic. There's 128 academic articles on it. Like I said, only 8 are from me, but I'd be happy to talk more either today or maybe by email later if people have questions about anything I've written, or if you just want me to try to find, like, hey, does the literature say anything about how this affects critical access hospitals or hospices or just any specific piece.
I want to wrap things up, I guess, from my perspective. At the end of the day, in 1974, these were required specifically to restrict access. That's why the federal government put them in place, to restrict access to health care so people wouldn't go to health care facilities, so they wouldn't have to spend the money for them to go. What you've heard tonight is it was successful. The thing is, the federal government figured out in the 1980s this was a bad idea and it wasn't working. We just haven't. And I think Ms. Kavanaugh, touched on it. It's not because it's good for patients. It's not because it's good for continuity of care. It's because of political implications. We're a very small state, and the ability to influence the political decisions is very easy to happen. This is something where there's no question in my mind that if we were to pass this, either one of them to a certain degree, but specifically, obviously, I'm a Republican. I love the full red strikes. We would, within several years, see increases see the statistics and see increases in the quality of care in this state in terms of access. Because again, these were designed to restrict access, and we still have them, which means we are artificially restricting our access to care for every member, every resident of the state. And again, I'll say it again, I have no doubt that part of Brown Hospital's decision, or Brown, whatever it is now, to go into Massachusetts is partially associated with this. And if that's the case, where are they going to make their large-scale capital improvements going forward, Rhode Island or Massachusetts?